This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters Television for Life, coping with chronic pain. 100 million Americans suffer from it.
It's been a humbling experience for me to have to sit back and say I need help.
A Spokane woman shares her struggles.
I miss a lot of things that I'd like to do, especially with my grandchildren.
And how she copes.
Friends, support, a great husband. Those are the things that you need when you have this kind of pain.
Finding relief as Health Matters looks for ways to manage pain. Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
If you read Providence's mission statement, it's all about delivering quality care to the patient at all times. I'm Dr. Peter Rinaldi, and I chose Providence because they put the doctor-patient relationship first.
Find your doctor online at phc.org.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
Good evening, I'm your host Teresa Lukens, and welcome to another edition of Health Matters. Tonight, coping with chronic pain. An estimated 100 million Americans suffer from it. Whether the pain is from arthritis, surgery, fibromyalgia, or an old injury, there are ways to get it under control. Here to bring their perspective and their expertise, our panel this evening. Dr. Christopher Valley works for Arthritis Northwest and practices naturopathic medicine. Dr. Valley specializes in chronic pain management. Cheyenne Newsome is a clinical assistant professor in the Department of Pharmacotherapy at Washington State University's College of Pharmacy. Sonya Wood is a clinical psychologist. She works in the Pain and Psychology Department at St. Luke's Rehabilitation Institute, where she specializes in chronic pain. Dr. David Burns is an anesthesiologist and interventionalist. He works for Providence Anesthesia Services. And Dr. Ryan Barnes works for the Rockwood Physiatry Center. He is trained in physical medicine and rehabilitation. And I want to thank all of you for being here tonight. It's an important topic, and we do welcome you to join the discussion. Please email or call us with your questions. You'll see the phone number on your screen. And let's first start by talking about the role each of you play tonight so that our viewers know how to address their questions. And it's important because I think we really do have a good team approach tonight. And Dr. Valley, let's start with you.
Sure, thank you. So, as you said, I'm a naturopathic physician. I've been in practice about 12 years now, initially in family medicine, but now with Arthritis Northwest. I provide complementary treatment for most types of chronic pain, including musculoskeletal pain and neurologic pain. I'd say my number one specialty, though, currently is fibromyalgia. And
that's because it's become such an increasingly prevalent condition.
Yep, sure has.
And we'll talk more about that. Dr. Burns.
So I'm an anesthesiologist. I work in both pediatrics and an adult. My specialty is more geared towards the treatment of acute pain, pain that is associated with surgery or trauma, as compared to chronic pain, which is expected to last longer than a few days or weeks.
And Sonya?
So as you mentioned, I'm working as a psychologist at St. Luke's Rehabilitation Institute, specializing in chronic pain. And about half of my time is spent working in what you call a structured, intensive, multidisciplinary program that is specifically designed for injured workers who have been injured on the job and due to chronic pain have had difficulty getting back to the workforce. And about half of my time is spent with individuals outside of the program, not necessarily with L&I, from all different aspects of pain management. Working on cognitive behavioral therapy techniques, relaxation techniques to help manage pain and negative effects of pain.
And Cheyenne?
Yeah, so like you mentioned, I am an assistant clinical professor at the College of Pharmacy at WSU, but I also have a chronic disease state management at the Veterans Affairs here in Spokane, and I see patients in an outpatient setting for chronic disease state management.
Okay, and finally, Dr. Barnes.
Hi. I'm a physiatrist. I work at Rockwood Health Systems. I specialize in the diagnosis and treatment options for a variety of musculoskeletal pain disorders, arm pain, leg pain, neck pain, back pain, focusing on first the diagnosis of determining the cause of pain and then outlining treatment options to manage the pain.
Now, treating pain has changed quite a bit in recent years, Dr. Valley. We're approaching it much differently than we used to. We're not just throwing pharmaceuticals at pain anymore, although some work effectively, but as we mentioned, the team approach really comes into play.
Yeah, I mean, in my world, and I know in your guys' world too, collaboration is really key. I know that I'm good at some things. I know what I'm not good at, and I rely on these good people for the areas I'm not good at. In fibromyalgia, I think I'm good at education. I think I'm good at guided exercise programs. I do some pharmacotherapy as well. But when it comes to stress management techniques, I refer to people like Dr. Wood and her colleagues. Some of my folks need injections, and I refer out. So collaboration's key, and I think we need to work together as much as we can with chronic pain.
How do we, you as a doctor, first approach when a patient comes to you and has pain issues? Where do you begin?
Listening is the key initially. Most of the folks that come and see me have seen a dozen people. They're frustrated, they don't know what they have necessarily, and they often feel like they've just kind of been swept under the rug. So listening is key, taking a really good history. I pride myself on a pretty good physical exam, and then again, collaboration with other partners.
Dr. Burns, you quite often work with kids at Children's Hospital. Is that a whole different approach because kids handle pain differently, or do they handle pain differently?
Oh, they definitely do. And the types of pain that kids have that become chronic is oftentimes vastly different from what adults have as well. What the majority of the work I'm doing at the Children's Hospital is to try to make all the needless pain that we cause to children when they come to the hospital to be as cared for as possible, as well as possible, with all the best practices in minimizing the pain from especially things like needle pokes. If you ever take a survey of children and what's their greatest fear in coming to the hospital, it's always far and away needle pokes. I don't want to get a shot. Don't get the needles near me. And so we've introduced a comfort promise where we at the hospital are promising that as part of the care that we provide the children when they come into the hospital, that we'll do everything we can to eliminate all needless pain. That is, unless in an emergent situation, the life of the child demands that we just do things as quickly as possible. But if that's not the case, where we have the time to do the best practices, we try to provide topical numbing. We provide good distraction. We have a wonderful team of child life specialists there. We put them in positions of comfort. You know, oftentimes people feel very scared about being held down on a bed and to put a needle in their arm and stuff like that. And so we try to have them upright in their mom's arms, or if they're older, being distracted with their iPad or iPhone or something like that, watching a movie. Some of the things that we've brought into the hospital are things like goggles where they can watch a movie in the MRI scanner so that they don't have to be sedated or put under anesthesia. A lot of things that have really helped ease a lot of the pain and the anxiety that is associated with children coming into the hospital.
It's even become less clinical in the surroundings that you have at Children's Hospital. It's more inviting.
Right.
So it's not as clinical as it used to be.
Good colors, good warm environment, lots of flowers and stuffed animals.
Yeah, I like that a lot. The benefits of psychological approach to pain. We're finding out a lot more about that as well.
Yeah, pain doesn't seem to stay in a bubble, so to speak. It doesn't even stay put physically. For example, if somebody has a pain in their knee, especially if it's a chronic pain, they might start limping. Then all of a sudden they have pain in their hip. In the same way, pain doesn't even seem to stay put mentally, and it can affect the way that we think, the way that we feel, what we do with our lives. And yes, those things can come back and play a part in how we manage pain. And so from a psychological aspect, what we get to do is look at the whole of a person's functioning. What's the pain? Yes. but also, like I said, what are the negative effects of pain, and is there anything that we can do to minimize that? The effects of pain might not even just stop with a person. It can affect those around them. There was a cartoon printout I recently saw at our work, and it was something along the lines of a woman speaking to a physician about chronic pain, saying, you know, the pain starts in my husband's lower back, and then it kind of reaches up to his neck, and then it comes out his mouth, in my ears, and that's when I get these headaches.
Oh my.
And it just speaks to even relationship difficulties that can happen because of pain. So all encompassing, and we get to do that from a psychological perspective.
So what kind of tools can you give people to do that?
Most of what we employ is called a cognitive behavioral therapy approach. So cognitive simply referring to your thoughts, the way that we're thinking, behavior is what we're doing, and then emotions will play a part too. And we look at what are the thoughts that are helping, what's not helping, what are the behaviors that are helping, what's not helping. And we look at your work, your school, your relationships, or if there's none of that, the isolation, the lack of progress, and see what there are things that we could change.
Very interesting. So it's a process then. It's a marathon and not a sprint.
That's a good way to say it.
Cheyenne, pharmaceuticals obviously come into play. A number of over-the-counter treatments available, as well as opioids, which we're finding out have become a huge issue in this country and in Spokane County. In fact, a recent report stating that we're up 70% with opioid addiction. So there's a fine line there of treating the patient and making sure we're relieving the pain, and yet making sure that we don't find these addictions. And that's something you have to deal with.
Right, definitely. When we're treating pain, we really have to decide the severity and kind of go at it with all of the different tools that we have to use, and not just immediately go to drugs. So yeah, there are a lot of over-the-counter medications, so your ibuprofen, your Tylenol, that can be very helpful. You just need to make sure when you're using those medications that you're following the labels, because if you think 2 ibuprofen are helpful, 4 are more helpful, 10 are even better, you can get into trouble if you use more of those medications than recommended. And like you said, the opioid epidemic has hit the country hard, but Washington State and Spokane as well. And there are, as we have more prescriptions for opioids, there is a higher risk that people overdose on those medications, either accidentally or if they're getting them illegally to obtain kind of, a euphoric effect as well. So for patients who are taking opioid medications and end up having an overdose, there is a reversal agent that we can use for them. And I think it's important that we spread that word around our community so that people can have that available to them.
Is it readily available, and what is it called?
Yeah, so the name of the medicine is naloxone, and it's a prescription medication, so you can go to your doctor and have your doctor prescribe it for you. And even if you don't take opioids yourself, but maybe you have a family member who does or a friend who does, you can also get it. You don't have to be the patient in order to get the prescription for the naloxone. So you can go to a doctor to get it, and there's also several pharmacies in the area that have agreements that they can provide it without a prescription from a physician.
So what exactly does it do?
So it works by blocking the opioid receptor. So it kind of takes the opioid away from the receptor so that you won't have the respiratory depression or the problems breathing that can cause significant harm or death in opioid overdose.
So it doesn't cure the addiction.
Right. Oh no,
Let's
no.
be clear
It's
on
just
that.
right. It's just a immediate, urgent situation reversal that's very quick acting.
Okay. And Dr. Barnes, we want to get to you. Physical therapy and working with patients in that manner. That's a tough one, because if somebody's in pain, they don't necessarily want to go through that process.
Yes. And physical therapy is one of the things that we prescribe, and in certain cases it's helpful, and in certain cases it's not. My experience, acute pain when people have severe, they're having a hard time moving around, a lot of times therapy is not quite as helpful, but there are a lot of other things we can do to try to manage the pain. And in psychiatry, one of our roles is to get a good diagnosis, evaluate the pain, and we can a lot of times recognize when therapy is going to be helpful, which is in a lot of cases. But one thing that's also important is therapies work. Usually results from therapy take a little time, and then providing the patient with the right education about what are the goals of therapy, why you're going there, and setting realistic expectations can improve outcomes.
And making sure they continue that therapy, because I would imagine, again, being in pain, it would be easy to say, I just can't do it today, that sort of thing. So keeping them motivated.
Yes, a lot of what we do is, even at Psychiatry, we do a lot of patient education and coming up with strategies for maintaining the successful exercise program. There's certainly data out in the research world that exercise for fibromyalgia, for example, is quite helpful, but the data also suggests that when people stop working out, they lose all those benefits.
And, that's something we can also address from the more behavioral approach with psychology treatment, because there is a lot of not just fear of increase in pain with something like physical therapy, but possibly even a fear of further physical damage. And sometimes that does get helped with an educational component, and sometimes the physicians don't even have the opportunity to do that, or the concern is underlying and the patients aren't bringing it up. So that's one thing we can bring up is, how's physical therapy going, or how's another treatment going? You're not going, what are the issues? And to bring them up and to either decide if it's appropriate to continue or not, and address some of the fears that are underlying. I mean, that fear of avoidant behavior can keep us from progressing forward, not just in physical therapy, but in the things that we enjoy and the hobbies. And I mean, that's what people want. But if there's something getting in the way, we might be able to address what it is.
Okay. Chronic pain can stem from all kinds of things. The key is finding ways to get it under control. For a Spokane woman, success came not only from her doctor, but from the support of her family and friends. Let's meet her.
For Connie Pace, navigating the grocery store in a scooter has given her a new lease on life.
I can get in my little scooter and scoot around and shop and not have to worry about every step hurting.
Connie suffers from chronic pain. She has good days and bad days.
With chronic pain, you don't know what your day is going to be like the day that you want to go somewhere.
So she plans around the pain.
I like to make most of my appointments at 1 or after, because in the mornings it's a lot harder for me to get going.
But even that isn't always enough.
I miss a lot of things that I like to do, especially with my grandchildren.
Connie's pain is a result of hip surgery.
I had 4 surgeries on my right leg and 2 surgeries on my left.
Connie manages her pain with medication released from a patch.
If I'm taking pain medication, my level's at about a 2, very manageable. Without it, it's usually at 8, 9, can even be as much as a 10.
It's a daily struggle.
There's not a minute of any day that you don't have pain.
Along with medication, Connie seeks relief through massage, chiropractic, and physical therapy in the water. But what really gets her through is her support system.
Friends, support, a great husband, those are the things that you need when you have this kind of pain.
It hasn't always been easy.
It's been a humbling experience for me to have to sit back and say I need help.
But through it all, Connie is determined not to let chronic pain keep her down.
You can still have a good life, you can, and a lot of it's attitude, a lot of it is counting your blessings.
Well, and quite obviously, Connie does have a good attitude. How much of a role does that play?
Well, attitude's huge. The way that we think about ourselves, our world, the environment, that's going to determine how we feel and how we behave. So attitude's big.
Mm-hmm. And I believe she uses a pain patch. That's become a popular treatment as well for localized pain.
Yeah, there's patches that are used just applied right where the pain is, like lidocaine patches, and they just kind of numb the area. There's also patches, which I think is what she had. It's an opioid patch. So it releases the opioid into your system, but you don't have to take it orally, and you can leave it on for 3 days so that you get that consistent level of pain management.
Is it a safer method?
Than
more controlled?
Taking oral. It just gives you a more steady state level of pain relief in your body. So in that way it can be easier, more convenient for patients is kind of the benefit of the patch.
Okay. We have our first phone caller this evening. We have Elma from Lethbridge. Hi, Elma. Thank you for waiting.
That's good.
Do you have a question?
My question is, on your panel, do any of you know anything about the low-intensity laser treatment that you can get?
For which type of condition, Elma?
For pain like arthritis or muscle pain, or if you have an injury?
In general, for chronic pain, the evidence supports that most passive modalities, which this would include modalities that where you receive treatment, has very limited long-term benefit. I imagine, if anything, it'd be a short-relieved. I haven't seen too many patients who receive a lot of success with the cold laser treatments.
I would agree. I mean, for chronic pain, I think the data is pretty limited, very short-lived. Some acute pain syndromes, though, might respond, and there are PT groups around that offer that. I know that there's some chiropractors as well that offer that, but that's more on the acute side.
Okay.
Yeah.
Dr. Valley, fibromyalgia is one of your areas of expertise, and again, this has become a huge issue. And a lot of doctors, I don't want to say don't treat it, but don't find it easy to treat. Would you say that?
Oh, no doubt about it. I mean, it's a complex problem. It takes a lot of time, and that's something that most primary care physicians don't have in abundance. They don't have much time. It's multi-layered. It's not just pain. It's often depression. It's usually sleep disruption. It's often headaches. It's often GI trouble. I mean, there's a whole list of things that can go with it. So treating it in a primary care setting can be challenging as it just consumes so much time. In my practice, I'm fortunate where I can spend a little bit more time with patients, but again, I rely on some of the other experts in the community to do the things that I cannot do.
What are some of the treatments available that you're finding?
So the data supports, as Dr. Barnes was saying, the data supports the top two treatments right now really start with education and exercise. In fact, there was a study published in July of this year by a group called EULAR, which is a large group. It's the European League Against Rheumatism, and they showed pretty clearly that exercise was the strongest modality for fibromyalgia. In fact, it wasn't even close. The medication therapies for fibromyalgia were kind of a distant runner-up. Now, that being said, I do use some medicines. If somebody has severe depression, severe sleep trouble, severe pain, I do use some medication in addition to that, but I'm inherently a minimalist, and so I lean on exercise and I lean on education for these patients.
That brings up another challenge with fibromyalgia is exercise is the best evidence, it's the most effective, but it's also the hardest one to do because almost every patient I see that has fibromyalgia will have the same experience, that if they overdo it, which sometimes doesn't take much, they're miserable for a few days. It's one of the kind of classic symptoms of fibromyalgia, and so part of the education is learning the pace and kind of find your limits and not overdoing it.
Yeah, without question. That's a great point. So when I prescribe exercise, I actually prescribe it. So it's actually written down on a prescription. I start them very, very small, sometimes as little as 5 minutes, and I graduate them by a minute or two a week within their boundaries. I actually ask them to schedule it. I have them put it on a planner so they have the visual feedback. I think human beings are a little better with appointments than we are with abstract concepts, but Dr. Barnes is right, and there's an inherent fear about exercise. That caused me pain before. Why in the world would I do that again? But if you can educate them that the pain that they experience is transient, it's not life-threatening, it's not damaging, it hurts, no doubt about it, but I think if you work with them on a slow, gradual program and get them to feel some glimmer of success, then they're more apt to want to build on that.
And Cheyenne, you wanted to add?
Yeah, and one thing I've noticed a lot with patients with fibromyalgia or nerve pain who are being treated with medications is that it usually takes a while to figure out the right medication for them. And sometimes the first medication doesn't work, and then so just the medication trials and starting slow and increasing the dose, it can take kind of months before you find the right medication that may be helpful to them.
Okay. Dr. Burns, I want to get back to you in your area of expertise. You use a regional anesthesia, which is, I guess, what we traditionally know as a nerve block. How has that been successful in what you do?
So, in related to chronic pain, there's evidence that if the pain that we cause from surgery is well treated at the time of surgery, that the likelihood of it progressing to chronic pain is much lower. So some of the things that we're doing in Providence is trying to do a multimodal approach to pain with things like anti-inflammatory medications, Celebrex and ibuprofen medications, as well as opiate medications, and gabapentin, things like that are taken orally. Then injections at the knee at the time of surgery by the surgeon with some local anesthetics and some anti-inflammatory medicines. And then nerve blocks by the anesthesiologist that provide numbing to the nerves that would feel the pain from that surgery. And so that after surgery is done, the signals of pain are never sent to their brain. And then those signals, when they're at their most intense, those first few days after surgery, are never sent to the brain, then the brain never gets that wind up of, this is a pain condition that I'm always going to have. And so as that nerve block is then worn off, and they then transition to just being able to manage it with oral medications and things like that, they've gone through the peak intensity of their pain without ever feeling the pain.
So can they get to rehabbing faster, and
absolutely
the healing process begins a little quicker?
And they're not limited by thinking that they're going to be damaging their knee replacement, for example.
Not being so ginger with it.
Not being so ginger with it, and being as aggressive as a therapist need them to be to maintain good function. And the function is really the key to pain relief.
Are there any side effects to using that type of treatment?
So depending on which nerves are numbed, you have nerves that feel and you have nerves that control muscle. And oftentimes they're bundled together. And so some of the techniques will cause like when you get an injection by the dentist, that your face is all droopy and you drool when you try and drink anything, because the sensation is blocked, but also the motor function of those nerves are blocked as well. And so that's the challenge, is trying to be able to control the pain and minimize how much weakness is caused by the numbing. There are areas that are purely sensory, which you can do, that provide great pain relief without any of the side effects of weakness.
We have all kinds of phone calls coming in now, so we want to get right back to those. Lois in Idaho. Hi, Lois. Thank you for waiting.
Hi, thank you.
You have a question?
Yes. Well, I just tuned in and I heard you talking about the fibromyalgia and all of that stuff. And I'm 66 now, but for all of my life, I've been suffering with all of these problems that people just wanted to chalk off to stress or whatever. I've been diagnosed with fibromyalgia, lupus, rheumatoid arthritis. But after having a fall last year, I found a doctor who actually did some tests to actually find out what was going on, did an MRI, and found out that my whole spine is screwed up, and that I have Ehlers-Danlos syndrome. And so what I found out about that, and it was verified by the rheumatologist, and so what I found out is that it's a defect in the collagen. And so I'm just wondering if maybe some of these people that are suffering like I have over the years might be, because my rheumatologist says it's a lot more common than people tend to realize, that this Ehlers-Danlos syndrome. And I also have dextrocardia, and he says that most people, he's found that most people with dextrocardia do have the Ehlers-Danlos syndrome. So I'm just wondering how many people are being misdiagnosed because the doctors don't know enough about this. And my sons are having a lot of the same problems that I'm having, and they're having problems because they live in other areas. They're having problems getting diagnosed with anything because their doctors are saying they don't really know anything about it, and they're saying, I don't really think you have it. So they don't even want to do the testing. My brother, also, because it is hereditary, my brother has been on disability for the last year, and he's had trouble all of his life with this.
Okay. Well, Lois, let's have our doctors address that, because, again, with chronic pain, sometimes diagnosis is difficult to nail down what is causing the problem.
Yeah, no doubt about it. And speaking to that particular condition, the spectrum of hypermobility conditions, Ehlers-Danlos being the more extreme end of that condition, but there's a spectrum. Many of my patients actually have something on that spectrum where their joints are very loose, the attachments are loose, and it can cause widespread body pain at all the insertion points where the tendons insert, and it can mimic something like fibromyalgia, and that can be an easy one to miss. Although, again, with good physical exam, hypermobile syndromes are not that tough to pick up. But the other point is there are a lot of other healthcare conditions too that can mimic fibromyalgia, and those have to be ruled out. Things even like, believe it or not, thyroid disease can sometimes mimic chronic pain syndromes. Vitamin D deficiency occasionally can cause widespread pain. Certain neurologic diseases, multiple sclerosis and some others can cause widespread pain. So again, this is where I think really good history taking, really good physical exam. I do my very best not to carry over diagnoses from prior providers and immediately assume that that's the correct diagnosis for my patient.
Fresh then?
Right.
Mm-hmm. Okay.
One thing that's important to emphasize too, though, is fibromyalgia is termed a syndrome, and in medicine, a syndrome is not a specific etiology. It's not like it has an underlying diagnosis, a pathogenesis behind it. It's a syndrome, so it's a collection of signs, symptoms that people experience, and they look similar. And so I always emphasize to patients, even though you have this fibromyalgia syndrome, it doesn't mean you have the same thing as another person with fibromyalgia. And at some point down the road, when we understand more about the etiologies of these different widespread pain syndromes, the terminology may become more specific. I think it's okay if you have a syndrome and no one has been able to find a good diagnosis. Sometimes that's okay because the reality is the treatment for a lot of these widespread pain syndromes is the same. So with Ehlers-Danlos syndrome, I mean, the treatment is going to be fairly similar. It's going to be, we recommend exercise. The medication options will be very similar. CBT is still helpful. So the treatments don't change a lot between these different diagnoses.
Okay. We have Jenny here in Spokane. Jenny, thank you for calling.
You're welcome. I wondered if there was an opportunity for... Oh, hello?
Yeah, we're still here.
Oh, if there was an opportunity for more public funding for screening. There's intestinal screening, there's cancer screening, everything. So why isn't there more of a van opportunity for people to be screened for pain potential?
Well, that is an interesting question. Who would like to take that?
Well, one thing to realize is that pain is extremely common. Most Americans will experience pain. 84% of people experience back pain at some point. So there is some controversy, but some people actually think we actually over-medicalize these diagnoses that we give terms. So I don't know how I feel about that, but there is a danger to giving a medical diagnosis for symptoms that most people feel and on a usual basis.
Mm-hmm. Is it because it's so broad? We're talking about injury or chronic pain or condition. It's kind of all over the spectrum.
If the caller was referring to screening for, I think she said screening for potential for chronic pain. I think that's actually a kind of a movement in medicine right now, is trying to capture higher risk groups, people that might be more likely to develop chronic pain syndromes as they get older. One of the things that we're learning is that there may be a connection between childhood and adult trauma potentially and the risk of developing chronic pain as you get older. And I think if we could do a better job potentially at really aggressively helping people manage that, the chances that would progress along the spectrum to a chronic pain disorder as they get older would fall. And Dr. Wood, I'm sure, can talk to that. I mean, the ACEs information that's out there and things. But that could be one area that I could see screening be very helpful.
And I think some additional screenings are coming into play already in physician offices, but also the general education to the public would be helpful too, just in terms of having conversations like this, making it known. It's an issue, and it can be very detrimental to a person's life. As we saw in the clip, I think a little bit earlier today, she was talking about how it's negatively affected many areas of her life, and just putting it out there. If it's of concern to you, bring it up.
Okay, very good. Margaret calling from Tabor, Alberta. Hi, Margaret.
Hi, thank you. I was just wondering if Dr. Burns has any information on stem cell treatment as an alternate to knee replacement surgery for osteoarthritis of the knee.
So that is some of the things that they are working on in injecting stem cells as well as cartilage to help develop the internal structure of the knee. That is the basic problem with most knee replacements, is that the cartilage is worn out and the bones are rubbing on each other and causing pain. That's still very preliminary. We don't have a lot of the results from any sort of the long-term studies as far as how effective that is and how durable that is. But it is interesting and potentially the wave of the future.
Mm-hmm. Well, and especially since we have an aging population and we're talking more about arthritis and osteoarthritis coming into play. So we're going to probably see more of that research being done. Yeah, absolutely. Cheyenne, I happened to go to the medication section of the pharmacy today. I just happened to be there. And I was amazed at the amount of treatments that are available. And it's not just in pill form. There's all kinds of gadgets now, electronic type gadgets and patches that you can put on. And do they work? And how do they work?
Yeah, so there are, there's, like you said, there's always been pills, but now there's creams and there's patches, and they can be effective, but a lot of them are used for certain types of pain. So if you have, say, muscle pain from, overworking your body, then some of the heat patches can be helpful. There's a cream that's for nerve pain, and it's actually made from peppers, capsaicin. It's a kind of a pepper cream that kind of dulls those nerves, so it's used more for nerve pain. So there are so many options now and that can be effective.
Should you always talk to your doctor before you use one of those, or just trial by error?
Yeah, definitely. Yeah, you should always consult with a healthcare provider before you start that. So, if you're in the pharmacy and, there's always a pharmacist there available to, tell them the other medications that you take and tell them the type of pain you're having and if the product that you're thinking about would be beneficial.
Mm-hmm. Any worries about interaction with any of those topicals and something you may take orally?
So one thing with the topicals, especially I think about like the heat patches, is if you do use another type of patch for pain, you never want to put that heat patch at the same location where your topical patch is. But for the other, it's always good, but most of the things that we apply topically don't get absorbed enough into our bodies to really interact with other oral medications.
Okay. Fran from Spokane. Hi, Fran.
Hi, I'm actually in Calgary. Thank you for...
Thank you, Fran.
No, that's okay. I have a question. The fibromyalgia seems to be a big topic, and that I developed after a car accident, which you hear a lot of. And I wanted to know the role of diet, and because at the Chronic Pain Center here in Calgary, that's one of the big classes you take, is the role of diet in managing pain, as well as sleep and other kinds of pain management. Any suggestions there?
Excellent question, Fran. Thank you. Dr. Valley, diet.
So yeah, the literature on this is still very young, but thankfully it's growing. There's emerging information on the role of anti-inflammatory nutrition. The issue with that, though, is that there's a lot of different types of anti-inflammatory diets, in quotes, out there. People are following different types of anti-inflammatory diets, and that can be a huge spectrum from more of a vegan diet to more of what's called a paleo diet, a hunter-gatherer diet, and then everything in between. There's a mixture on the research on what foods create inflammation, which ones reduce inflammation. but the good news is the research is growing, and the majority of my patients with chronic pain, I do put them on what I call a low inflammation diet, and that's primarily removing foods that are heavily processed, refined sugars, simple sugars, emphasizing good healthy fats, vegetables, something along the Mediterranean spectrum, probably Mediterranean leaning towards paleo hunter-gatherer. But again, the research is still young, but I do see some promise in it. In fact, there are a couple of rheumatologists in the area that commonly put their patients with arthritis on elimination diets. Local rheumatologists that do that, and actually the success rate's decent, where you see some reduction in pain. Now, it's certainly not a cure by any means, but it can be a pretty good complementary treatment.
And as you mentioned, so many things being put out there. So if you go to the internet and you start searching, what's a good source? Where should they go to find that information so that it can be viable for them?
In a perfect world, it would be to seek out a healthcare provider that's had the training in it.
Stay away from the internet?
Well, I mean, the internet's a blessing and a curse, as we all know, right? Dr. Google and there are some reliable websites, and then there's a whole bunch of fringe websites out there putting out misinformation, very often to sell products. And as a consumer, it's real tough to know the difference. I always recommend more reputable sites, things like Mayo Clinic and Cleveland Clinic, NIH website, the National Institute of Health, and others. But and again, if you have a healthcare provider that has some training in it, that's ideal.
Okay.
Yeah.
Grace here in Spokane. Hi, Grace.
Hi.
Thank you for calling.
I have a granddaughter that has trigeminal neuralgia, and she's in extreme pain, and she takes about 4 drugs a day, and it doesn't seem to help her. So is there any other treatment?
Sonya.
So in addition to the drugs, depends on probably what kind of dysfunction is in that person's life, if we're going to look at it from a psychological perspective. And also from some of the earlier callers, we can just hear the frustration and the lack of answer. And from what Dr. Valley was saying about diet, it may not be a cure. Every single one of these is kind of like one other coping skill, whether it's from coping from a psychological perspective, looking at distraction techniques. Even we were talking about that, Dr. Burns, earlier with acute pain. We do that with chronic pain as well. All of these little things add up, whether it's decreasing stress levels or focusing on working with your treating provider to find other medications, or if exercise is going to be appropriate for a condition like trigeminal neuralgia, that remains to be seen with a certain patient. But every single one of these adds up, and it's not a cure, but certainly there are other things than medication to look at. But also just appreciate the frustration with the lack of cure to begin with. I mean, all of these treatments are helpful and good, but one of the things that hasn't been said yet is simply recognizing how debilitating the pain is, that the pain is real. In some conditions, you can see it, depending on, for example, how the trigeminal neuralgia manifests in a person. There are some physical signs sometimes, but many times it's invisible, so to speak. So simply being able to be heard and being able to talk to somebody, whether it's a counselor, or somebody in their family, and having an understanding of what that person deals with can be helpful.
Well, and then becomes added stress for them as well, which can contribute to their condition.
It's a vicious cycle. From a psychological perspective, it's not always preaching that, stress is what's causing the pain. Many of these conditions, many of the patients that I see, most of them, they start with some kind of medical diagnosis that's causing the pain. But that's exactly right. The reaction to the pain can be stress, and that stress can then come back and make the pain worse. So if there is any stress in a person's life, which there often is, sometimes the stress management techniques can serve as at least a helpful adjunct to hopefully finding some appropriate medication.
Okay. Carol in Cooley Dam. Hi, Carol.
Hi. I am an 87-year-old who's had fibromyalgia since before we had a name for it. I am on Lyrica 4 times a week, and my biggest problem is sleep or lack thereof. When I get a good night's sleep, my fibromyalgia is much easier to handle. Can you give me any help on this?
All right, thank you, Carol. In fact, we haven't even talked about sleep, and this does play a huge role for patients. It's either they can't sleep because they're in pain or vice versa. That's a tough one to tackle.
It is, and it does go both ways. The pain, even if a person never originally had a problem with sleep, the pain can be causing the sleep problems, and then lack of sleep has been shown to come back and make pain worse. I think Dr. Barnes was talking about earlier, maybe before the show, about the struggle in trying to find where to break that cycle. One of the things we can look at from a behavioral standpoint is, even though pain might be one of the original things causing the lack of sleep, there are other behavioral dynamics that we might be able to do just to tweak with natural sleep hygiene techniques that could be helpful to at least offset the amount that pain is interfering with sleep, in addition to medications that may not even be for reduction of pain but for sleep, which has its pros and cons there. But looking at behavioral changes can be helpful.
Some basic techniques, would meditation play a role, or something she could do just before bed?
So relaxation techniques, meditation techniques, they may not be known as sleep strategies, but one of the things that happens with pain is our body can just be in a constant fight or flight state. And when we're like that, we can't even relax enough to do what our body wants. So if there is something that's interfering with sleep because of pain, if we can counteract that by eliciting what we call a relaxation response, either through biofeedback techniques, relaxation techniques, perhaps meditation techniques, that additional problem that's interfering with the sleep can be taken care of, even though the initiating pain's not taken care of necessarily, so it can still help us sleep.
Dr. Barnes, any suggestions?
I agree with Sonya. There are some sleep books out there. I read one myself called The Insomnia Answer, and it looked like it had different approaches, behavioral approaches to managing sleep. There is the literature talks about sleep restriction, and then there's one other sleep restriction, and there's one other form that have been shown to help a lot of people with sleep. And there's some books out there that can help. Myself, I try to prescribe medications sometimes that do have sedative effects that have been shown to improve sleep. The success rate's hit or miss. A lot of the medications have a lot of side effects. A lot of times they're not tolerated, but sometimes they are helpful. If you talk to a pain specialist, they should know which options are available.
Okay. We have an email. Oh, Dr. Burns, please.
I was going to add to that is some of the stuff that we try to do in the inpatient side in the hospital is that, because sleep is very important, and the people can cope better with their pain and their chronic medical conditions or their acute surgeries or whatever it is that they're in the hospital for much better if they sleep well. And so some of the things we try to do are, if anyone's ever been in the hospital, sometimes you get somebody coming in to take their blood pressure or give them medication every 15 seconds, it seems like, and you never get a moment's rest.
Seems like they're trying to keep us awake.
Exactly. And so some of the things we try to do is cluster the care, so that maybe that we don't take the blood pressures and vital signs and stuff until they're ready for a medication, and we try to span out the delivery of those sort of therapies so that we minimize that at nighttime. We try to open up the windows and have the sunshine come in during the daytime to help them get in the appropriate circadian rhythms, that they can also have a healthy sleep cycle, so that, if anyone's ever had a teenager, their ability to cope with life if they're not getting enough stress is horrible. And so if you can get them to go to bed at the same time every night and wake up at the same time every day and not have a horrible sleep cycle, not only does that translate into coping with life as a teenager, but coping with pain.
Get into, just like we do with our babies. We need to get our teenagers and adults back to that same system. We have an email from Donna that we want to talk about. She says, please address cannabis and any pain relieving properties that it may have. Who would like to take this? I'm looking at Dr. Valley.
Look at the nature path for cannabis. I'll also punt some of this to our resident pharmacist as well, but the literature is, again, still very young, very mixed. The problem with researching cannabis right now is its schedule. Schedule 1 drug, correct?
Yes, correct.
And so the research opportunities are limited into cannabis, and our abilities to really look at the pharmacology of it, isolating compounds from cannabis and what really targets pain, how cannabis interacts with other medications, very limited. And frankly, I don't personally recommend it, because I cannot tell a patient confidently how a certain cannabis strain is going to interact with drug X, Y, or Z that they may be currently taking. There just isn't great literature out there. I wish that there were, to be honest. I wish they would do some deregulation of that so we could study it a little bit more. But
Right, yeah, totally. And so right now there isn't any kind of standardized formulation of cannabis as well. Yeah. So even if you were to, have a patient tell you what they're doing, it's so hard to know kind of how much cannabis they're using, if they get it from different sources, to know even just for an individual patient what they're doing.
Okay.
We'll even look at for example, the longest, oldest medication we've ever had for pain, opium or morphine, and that we still use. We still have struggles using that medication. And we've talked a little bit about the opioid epidemic that we've had right now. And an interesting thing about it is that a lot of times people don't realize that opioids, they really are a two-edged sword. They can be great to help control pain, especially in the acute phase, but in the long term, oftentimes they are the culprit for making patients have a lower threshold for pain. Mm-hmm. They develop a tolerance to the medication so that less and less effect is received by the same medication dosage. And what happens is that their whole pain pathways and the regulation system that involved with opioid receptors and such in their brain is altered by chronically being exposed to these opioids, so that they actually feel more pain when exposed to a pain stimulus, or things that aren't usually painful become incredibly painful for people that are on opioids. And so a lot of times, we had a big push several years ago of making pain the fifth vital sign, and we really need to make sure we are taking care of pain. And I think we really exploded the prescription of opioids in the population, where a lot of times, inappropriately so, and have done more damage than good with that. A lot of times patients would, in a chronic especially condition, do better getting off of the opioids.
And we're seeing that come back around then.
Right, yeah, and with opioids as well, the recommendation is to use them for the smallest dose for the shortest period of time that you can. So for acute pain, we want to, make sure that they're just using it when they're needing it and not using it, around the clock all the time, so that when they are, recovering from their knee surgery, that we can get them back off the opioid, and so that it doesn't become a chronic long-term need for them.
Mm-hmm. So smaller prescriptions as well. You'll get just a few pills to treat rather than a full course of
Exactly,
of
and
pills.
and explaining to patients, a lot of time the bottle will say every 4 to 6 hours as needed. So that means when you feel the pain, you can take it, but you don't have to take it, 4 or 6 times a day if you're able to manage your pain. And that's another thing, is understanding that a lot of these medications or these conditions, we're not going to cure your pain. We're going to make it at a manageable level. And I think the patient we had the video on earlier, said she was at a 2. So just knowing that we're not going to completely eliminate it, and just needs to be a level where you can manage your life.
Okay. We want to get Marge from Edmonton in. Hi, Marge.
Hi.
Thank you for waiting.
Thank you. Well, I have a question about polymyalgia rheumatica that's been diagnosed and on an adult child, and I wondered if there was a different, if it was related to fibromyalgia, and whether or not it's like in the same family, and the treatment seems to be long-term use of prednisone, which has its own set of major complications. Mm-hmm. So would diet have any help, or what can you tell me about it?
Okay, thank you, Marge.
So, full disclosure, I'm not a rheumatologist, but polymyalgia rheumatica is an autoimmune disease. It has no relationship to fibromyalgia at all, characterized usually by significant pain and stiffness, primarily in the proximal muscle groups, shoulders, hips, and upper legs, considerable pain. On blood testing, usually elevated inflammatory markers. The treatment is initially corticosteroids, although we try to bring them down as quick as we can, and very often we need to add a medicine so that we can bring down the steroid quicker. The most common drug used there is methotrexate. Dietary influences probably have limited impact for PMR. I've tried it ad nauseum, and I've not seen much result at all for it, unfortunately. The good news is most of the time it is a self-limiting disease. Treatment course is somewhere between 12 and 24 months usually, and the majority of patients after treatment go into remission, and most of them stay there, with exceptions, a few exceptions, but that's the good news.
What about physical therapy? Would it help in those conditions, in that particular one?
You know, this is not a diagnosis I would usually recommend physical therapy, because it's not a mechanical diagnosis, it's an autoimmune disease.
So the movement or the stretching wouldn't help?
Well, exercise would be beneficial, but usually when I prescribe physical therapy, I prescribe for a specific reason. We're looking for a specific mechanical problem, which is, it could be weakness somewhere, it could be poor muscle control, it could be tightness somewhere. Because physical therapists, their skill set is recognizing those mechanical contributions to their functional limitations. Now, for something like polymyalgia rheumatica, it's an autoimmune disorder, so it's not a mechanical problem. So things like a regular home exercise program, walking, swimming, bicycling, are going to be probably just as effective as seeing a physical therapist.
Okay, we just have a few seconds left. Just some final thoughts. If people are experiencing pain, and quite often they'll try to cope with it on their own, but is the best advice to seek help and take this team approach to their therapy? Dr. Valley?
Absolutely. I think that's the stepping off point, is that patients feeling comfortable about asking for help, recognizing that it's a scary thing that they may have, be willing to know what they don't know, and really, I think, kind of insist that whoever their provider is really help them with collaboration of care. What I found doesn't work very well is when one provider tries to manage all of the chronic pain. So that would be my advice.
Take the team approach and be an active player in your care as well.
Without question.
Yeah. Well, that's going to do it for this edition of Health Matters, and I want to thank all of you so much for being here and for emailing your questions and phone calls. We hope you'll join us on January 19th when we'll be in the kitchen cooking up healthy dishes so that you can eat well this winter. Travis Dickinson, he's the executive chef at Clover Restaurant, will be our guest. And Chef Travis uses inventive cooking techniques to transform local seasonal ingredients into tasty dishes that you can make at home. Again, that is coming up in January right here on KSPS. Until then, I want to thank you for watching. I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
If you read Providence's mission statement, it's all about delivering quality care to the patient at all times. I'm Dr. Peter Rinaldi, and I chose Providence because they put the doctor-patient relationship first.
Find your doctor online at phc.org.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?